So what kind of models are out there? So I think one I've mentioned before, the traditional models. Experts come together and now they are doing it virtually, but there are other models as well. So the first one I've described is tumor board meetings, right? So they all come together, no patient present, but you need to protect your time. So it's either after work hours or during work hours where everyone can come together. But now we also have something called integrated MDT clinics. Now, this is where, and I'll show you an example of what we are doing in Singapore. Specialists come together, they sit in the same room, the patient comes in, and each specialty gives their advice. Now, it sounds good for the patient, but it's not so good for the healthcare system, because how many of us can afford to sit there with a surgeon, with an oncologist, and only see 5 patients or 6 patients in one morning, right? For many oncologists, we can see triple the number of patients, 15 or 20 in one morning, right? Maybe in Indonesia, even more, because there's so many patients here, right? So high manpower, you need space, and it's very costly to the healthcare system. So this is a luxury. I don't really recommend it, but for the patients, it's wonderful. One time they see all the specialists at one go, yeah? What has changed, of course, is virtual MDTs. Now, virtual MDTs are great because you can be anywhere, right? Sometimes some of my doctors are also driving their car. I don't recommend that because you can't pay attention, and then you will be part of an MDT next time, of the orthopedic doctor, yeah? So, but the good thing is you can be anywhere. I can be here, and later I can be sitting on an MDT that's happening in Singapore or somewhere else. Why I highlight this is it may be an opportunity for also UGM and National Cancer Center to form some MDT collaboration as well, where you can discuss some cases and we can learn from each other, because this can be cross-country and it's part of what we call global health, right? So that's an opportunity there. So I'm just going to go through what we do with that integrated model, which as I say, I don't really recommend because it's very resource intensive. So in the MDT that I do, GU stands for genitourinary. So I specialize in urological cancers. I do prostate, bladder, kidney, and this is the model of MDT that we have there. Usually it's just the usual tumor board meetings. We do it in person once, and then the rest of the time in the month will be virtual meeting, right? So it's online. So it's the specific one, the integrated one, is a one-stop clinic. Each consultation is about 20 minutes. But before the patient comes in, we have the full MDT first. So we are discussing the patients, we have a plan. So when we start the clinic's only held once a month. Patients come in, we know what to tell the patient. So each specialty, the radiation doctor, myself, med-onco, the urologist, we know exactly what to tell, depending on the case. So sometimes uro may have more input, sometimes radiation may have more input, sometimes I may have more input. At the end, we also want to see, is this what patients want? So we do a survey, just like an audit, to see the effectiveness of such measures, right, of running this clinic. So this was a study we published in the Proceedings of Singapore Healthcare about 2022, 3 years ago. So we looked at, I think, just roughly over 50 or 60 patients. And in terms of demographic and gender, it's definitely a bit more on the male patients because it's a urology clinic. Many are prostate cancer patients, right? This slide is very busy. It's a bit hard to see, but I just want you to see on the left-hand side is divided by tumor. And as we go, it goes by disease classification, recommendation, and treatment actualized. Now, recommendation is what we discuss in the MDT, right? So you just focus on the top one for prostate, is what we discuss. So sometimes if it's localized, the first case there, we offer radical prostatectomy or radiotherapy. These are the standards of care. Now, patients usually in a normal sitting will have to go one day, see a urologist, get appointment another day, see a radiation oncologist, and sometimes they get so confused, they come to me, a medical oncologist, and they'll ask me, which one should I do, Prof? Because radiation says should do radiation, surgeons say should operate, because they have their own biases. So sometimes I'm in the middle, but this clinic, we sit together. So they hear it together, and they decide together as well. So like the top one, the patient declined radiotherapy because of preference for prostatectomy, right? So that's the final outcome, the treatment actualized. So the results. So after that, we survey the patient. We give them a survey, ask them, are you satisfied? So the question we ask is, was this clinic informative? Did it reassure you and your family? Do you feel better after the clinic? Because very often, if you ask our patients and do a survey, after our consult, they are more confused sometimes because we don't have enough time in the clinic to tell them everything. So they have some preconceived idea, they go in, they get more information, but they don't have time to digest. But here, they feel very satisfied. So if you can see here, many of them are very satisfied or satisfied, more than 90%, yeah? Similarly, other questions, I felt that MDT helped speed up time to receiving treatment, right at the bottom here, right? Again, about 90% said they are very satisfied. So that's the value. These are the members of our MDT. There's radiation oncologists, pathologists, radiologists, and surgeons, yeah? So it's a mixed group. Now, let's not forget allied health. Now, whenever we always think, okay, doctors, must all come together, but allied health are extremely important in cancer care. They help improve symptom management, quality of life, they support nutrition, physical function, and all these help them tolerate treatment much better, right? They address their psychological needs, social needs. Many of these, as physicians in the clinic, we don't have time. We can't address these things. So our colleagues have to help us here. We enhance their understanding, adherence, and shared decision-making, right? And this strengthens the continuity of care and the survivorship journey. Many of our patients now are getting cured. They are becoming survivors, but that doesn't mean they can integrate into life normally, right? They still have many challenges. So an example of this is I run a program called Geriatric Oncology. Now, this is cancer in older adults. In Singapore, our cutoff age is 70. In many countries, it's 65 or 60, depending on the lifespan. But basically, we focus on older patients with cancer because very often, when somebody is 85 years old, walks into a clinic, most of us as oncologists, before they come into, sebelum masuk, sudah ada idea yang patient ini tidak perlu rawatan. Sudahlah, tua. Jadi, why should we give any form of treatment, right? However, now we have 85 years old that's climbing mountains, right? They're very fit. So we shouldn't be biased. So we should treat them holistically. So this is my team in the geriatric oncology service, right? So we have geriatrician, we have nurses, occupational therapists, physiotherapists. So we discuss their cases in an MDT once a week, mostly virtual meeting, and then we come up with recommendations. So number one, we'll give the doctor, the physician who's referring, an idea, should this patient get chemo or not. Very often we use the eyeball method. If patient walks in, looks fit, we're like, okay lah, boleh lah kita cuba chemotherapy. Tapi dalam 1 minggu, semua mual, muntah, yeah, all in pain and suffering because there were other problems that we probably couldn't assess just by eyeball, just by looking, right? So we need to do additional tests, physical tests, functional tests. So we have all these allied health specialists, right? So I think it's a team effort in oncology. So we must always try to use our allied health specialists who are keen in oncology and encourage them to help our patients. Now, last but not least, I want to highlight a bit on digital and data support. I think more and more AI and such technology is going to help us. I think there's been a fear in many other fields, including in medicine, specifically radiology and pathology, that AI will replace doctors. But I don't think that's going to be the case. I think it's going to be doctor with AI is going to be more successful than doctor without AI, right? So you need to incorporate AI into your day-to-day activities. So we have invested a lot of money in data engineering. That's building the infrastructure, getting all the technology in place. Data analytics. So we have 5 data scientists in our center right now who are helping us to pull out data from our electronic medical record. So if I have a question to ask, let's say, can you tell me what proportion of my geriatric oncology patients have breast cancer on targeted therapy? They take the question, they are able to pull out the answers within a day and let me know what the number is. And with that, I can then do research, I can apply for clinical trials, right? So there are many, many users for this. And finally, we're thinking of ways for digital solutions as well. So I think while it appears costly, there are some simple things that can be done. A lot of AI systems now have free versions, which may not be as good as the paid ones, but they are good enough, which you can incorporate in your day-to-day practice because your patients are using AI before they come to see you. So if you don't use the same AI, then you are going to be behind. and it will look bad, right? Because the patient will say, oh, tapi dalam AI tulis macam ini. And then you'll go, oh, yeah. So that's not ideal, yeah? So I think as far as possible, try to get used to the idea that this is going to be part of your day-to-day practice, yeah?